Today I'm going to continue with our discussion of Chapter 14, and I'm going to begin by talking about anxiety disorders. Anxiety disorders as a class are characterized by anticipatory worry about events that are going to happen as opposed to things that are happening. So, for example, people who have the class of anxiety disorders tend to interpret ambiguous statements as being the worst possible or the most negative kind of interpretation possible. As evidenced here in the chart, the statement, the doctor examined little Emma's growth, a person who's more anxious would see that as a growth that's pathologic tumor, as opposed to someone who's not anxious who might perceive this as looking at height and weight. So there are a number of different classes of anxiety disorders, and these include specific phobia, which is an exaggerated fear of a particular situation or object, social anxiety disorder, which is fear about being evaluated in social situations, generalized anxiety disorder, which is very difficult to diagnose. It's mimicked by a lot of different conditions. But basically, these are folks who are worried about everything. They are able to see the negative outcome in any possible situation. Panic disorder, which is when one has repeated panic attacks, that I'll talk about in a minute. And agoraphobia, which comes from the Greek for fear of the marketplace. Agoraphobia is an exaggerated concern that one will have panic attacks, so that if you leave, say, your house or some safe place, you're worried that you're going to have a panic attack and embarrass yourself or something terrible is going to happen. And these people can actually become housebound because of the excessive worry about this. So specific phobias are fears of a particular object or situation that is completely out of proportion to the actual threat. Now we see some interesting examples here on the slide. These are very rare examples of specific phobia. Typically, specific phobias are fears of things like animals, blood, heights, closed spaces, etc., things that actually have some danger. But, every now and then you get something like trichodecaphobia, the fear of the number 13. Social anxiety disorder, which also is known by social phobia, that actually used to be the diagnostic term for it, is the fear of being negatively evaluated by others in a social situation. Most typically you see this with people who are afraid of public speaking. They're concerned that they're going to make themselves look foolish or people are going to laugh at them. Generalized anxiety disorder, as the name implies, is this worry about everything. It's not tied to any particular situation or object. It's just everything is potentially dangerous or bad, or there's a negative outcome. And this is really difficult to diagnose. People typically get a number of different diagnoses before they get a correct one. I think the average amount of time people suffer with this before getting a correct diagnosis is about 7 or 8 years. Panic disorder is the fear of having these overwhelming panic attacks. And if it occurs repeatedly, it's called panic disorder. So a panic attack is the sudden onset of terror, feeling like you're going to die, you're going to pass out, you're sweating, your heart's beating fast, and you have this overwhelming sense of something terrible going to happen. In about half of the cases of panic disorder, people develop a condition known as agoraphobia. And agoraphobia is a condition in which people are so concerned about having a panic attack and not being able to escape the situation that they become more and more restricted in the kinds of places they can go. They don't like to go out into public because they might have a panic attack, and then they might pass out, or people will make fun of them. So it can actually cause them to be particularly anxious and restricted in their movements to the point where they become housebound. Now, there are a number of different ways that people develop anxiety disorders. It depends on the specific anxiety disorder, but there is some degree of heritability to this, sort of a general susceptibility to these. Many of them develop due to a bad traumatic experience, particularly specific phobias. In this case, there's a learned response, a classically conditioned response. Some of these occur via observational learning. People often develop fears or anxieties based on the messages they get from their family or friends growing up. If your family says, we should be very concerned about garden gnomes, then you may develop a fear of garden gnomes. Obsessive compulsive disorder used to be categorized under the general rubric of anxiety disorders, but it has its own category in the DSM-5. It's characterized by having obsessions and or compulsions. In almost every case, both of these. So the obsessions are these intrusive, unwanted thoughts. These are ideas that get fixated in your mind that you can't get rid of, and they are not something you want to think about, but you can't stop yourself. So, for example, if you've seen the television show Monk, or the movies Matchstick Men, or As Good as It Gets, you've seen a fairly accurate portrayal of this disorder. People typically feel things like contamination, dirt, germs, or that they're going to do something to harm someone that they love. Because the obsessions are so anxiety-provoking, people develop ways to reduce the anxiety. These ways are called compulsions. These are actions that the person has to complete over and over and over again. And as they do complete the action, they become less anxious. Now, the problem is that the compulsions tend to become more insidious, more extreme, more difficult over time. And so there's this escalating need to perform a ritual to get rid of the anxiety that takes more and more time and is more and more disruptive. So there's kind of a cycle here. People who are afraid of germs or dirt will compulsively wash their hands, sometimes to the point of causing dermatologic problems. They feel better, right? They've got some reward for doing this. They are less anxious. And then the anxiety comes again. They become more and more obsessed. And this ultimately leads them to conduct the ritual again. So there is certainly some evidence that this is partially heritable. Fortunately, this is something that is very treatable, though it's sometimes the treatment is difficult to complete. It can be somewhat unpleasant during the process. Trauma disorders, trauma and stressor-related disorders, are those in which there has been excessive stress or something really bad has happened. The one that we think about most often is post-traumatic stress disorder, or PTSD, where people have experienced some traumatic event or events, and they have nightmares or flashbacks around it. They typically have an exaggerated startle response. It's easier to startle them. And they have a sort of an emotional disconnect from other people. The areas of the brain that are affected by this include the amygdala, which is involved in emotional memory, the dorsal prefrontal cortex, where we evaluate threats from the environment, and the hippocampus, where we store memories involving events. A somewhat or a much milder situation is something called adjustment disorder. Adjustment disorders are when people have an excessive difficulty adjusting to some stressor. So, for example, people might have excessive depression or anxiety, adjusting to a new job, a new living situation. So the criteria for this are emotional or behavioral symptoms that develop in response to an identifiable stressor within 3 months of the onset of the stressor, plus marked distress or significant impairment. And these involve either depressed mood, anxious mood, or disturbances of conduct and or emotion. The trauma that causes PTSD is associated with particular kinds of events. And as you can see, the most common cause of this trauma is actually intimate partner or sexual violence. Now, we hear a lot about war-related trauma, people who've been either combatants or non-combatants in the war. But this is not the most common cause, partially because in this society, about less than 1% of people serve in the military. And so there's less, 99% of people do not have the risk factor of being exposed to war. Depressive disorders are disorders in which an individual has low or sad mood, or sometimes it manifests as being irritable. And there are two major classes of depressive disorders. There's major depressive disorder and persistent depressive disorder. Major depressive disorder is an acute condition that lasts for 2 weeks or more, in which people have depressed mood, loss of interest in pleasurable activities, which is called anhedonia, lack of hope, changes in sleep or eating. Persistent depressive disorder, which used to be called dysthymic disorder, and I think they probably changed it because that was so hard to pronounce, lasts for 2 years or more, and it's a more mild form of continuous sadness, more days than not, which is less dramatic in presentation, but very disruptive since it goes on for years and years. Major depressive disorder affects approximately 16% of Americans at some point in their lives. It's a very common disorder, and worldwide it's the most common cause of lost days of functioning or work. Persistent depressive disorder is less common, maybe about 2 or 3% of the population. So if you look at the graph here, Major depressive disorder is the blue line, and you see an extreme dip where there's a return to normal functioning, as opposed to the persistent depressive disorder, the orange line, which is more chronic but stable. Seasonal affective disorder is something that occurs at particular times of year, and it's more common when there's less light out. You can see it becomes more common as you move higher towards the poles, where there's less and less light. There is a relationship, obviously, between the amount of light that one gets and the symptoms of depression that occur on a seasonal basis. Fortunately, this is very treatable by using exposure to about an hour of full spectrum light that simulates sunlight for about an hour in the morning. Depressive disorders are a good example of ones that fit the biopsychosocial model. There is certainly a genetic component to this. There's certainly an involvement of various brain structures, such as the hippocampus and the anterior cingulate cortex and the amygdala. And there are changes in the amount of and receptivity to various neurotransmitters, in particular norepinephrine, serotonin, and dopamine. Psychological factors are also very important. One of the more influential therapies was developed by Aaron T. Beck, who died last year at the age of 99. Beck's idea was that people who are likely to develop depression blame their misfortunes on personal defects and see positive occurrences as the result of luck. So it's sort of the opposite of the self-serving bias that we talked about in social psychology. They also tend to exaggerate the intensity of events. A second theory is learned helplessness, which is the idea most developed by Martin Seligman, that suggests that people learn that nothing they do can make things better, or at least this is what they come to believe based on their experiences, resulting in them having a disproportionate amount of pessimism about the future. There is a consistent finding across many cultures that women are about twice as likely to be diagnosed with depression as men are. And there are a number of different attempts to explain this. One very common one is that women tend to respond to stressful events by internalizing their feelings, which leads to depression and anxiety disorders, whereas men externalize their feelings with alcohol, drugs, and antisocial behavior. And in fact, women have higher rates of anxiety and depression, and men have higher rates of substance abuse and antisocial personality conduct disorders. Another type of mood disorder, which is really in its own category, is bipolar disorder. Bipolar disorder is divided into bipolar 1 disorder and bipolar 2 disorder. So bipolar 1 disorder is when people have at least one episode of mania which is a elevated or irritated mood, and either intermittent depression or intermittent return to normal mood. Bipolar II disorders, when there's a major depressive disorder, interspersed with periods of hypomania, that is, you don't meet all the criteria for a manic episode. Kay Redfield Jamison is a psychology professor who has written about her own struggles with bipolar disorder, particularly in her memoir, An Unquiet Mind. A number of very famous and creative people are thought to have suffered from bipolar disorder. Michelangelo, Van Gogh, O'Keeffe, and Hemingway. Between bipolar 1 and 2, somewhere between 3 and 4% of the population will tend to experience a bipolar disorder during their lifetimes. These disorders are equally common in women and men. They typically start during late adolescence or early adulthood, and there are multiple overlapping genetic risk factors for bipolar disorder. Bipolar disorder not only affects mood, but it affects attention, processing speed, memory. It is treated with mood-stabilizing drugs or with electroconvulsive therapy. And it is characterized by these manic periods in which people have, for a week or more, very speeded thoughts, speeded speech, illogical jumping from topic to topic, lack of sleep, lack of appetite, and really poor judgment. They do things that are exciting, but tend to cause them extremely unpleasant responses from society, including the legal system. Schizophrenia is a very debilitating disorder that often leaves people unable to function on their own. There are extreme loss of rational thought, disruptions in perception. It's somewhere between 0.5% and 1% of people in the world, and it tends to be about the same everywhere in the world, and have about the same rate for men and women. There are motor problems, cognitive problems, behavioral problems, perceptual problems that cause excessive impairment in functioning and distress. And these symptoms must go on for at least 6 months to qualify as schizophrenia. So there are 5 symptoms that are required for a diagnosis of schizophrenia. These are delusions, hallucinations, disorganized speech, disorganized behavior, and negative symptoms. So, in order to qualify for a diagnosis of schizophrenia, one must show 2 or more of these symptoms, including at least one of the first 3. We can further divide the symptoms into positive and negative symptoms. Now, that's not meant to say that these are good and bad symptoms. This refers to excesses and deficits. So the positive symptoms are delusions, hallucinations, disorganized speech and behavior. The negative symptoms are lack of emotion, slowed speech, slowed movement, social withdrawal, apathy. The Delusions are these fixed, false beliefs that are based on incorrect emphases about reality. So, delusions often fall into a number of categories. For example, delusions of persecution are the beliefs that someone is persecuting, spying, or trying to harm you. Delusions of reference are that some event or object has particular significance for you, like the television newscaster is giving information directly to you. Delusions of grandiosity, that you are someone special, have great power, great talent. Delusions of identity, that you're someone else, like you're the president. Delusions of guilt, that you've caused some terrible harm in the world. And delusions of control, that are beliefs that you're being controlled by outside forces, that people are putting thoughts into your head, that they're taking thoughts out of your head. Another set of symptoms are hallucinations. Hallucinations are these perceptual distortions. It's perceiving something when there's nothing there. Usually auditory, but they can be visual, olfactory, tactile. The pictures on the right are a series of drawings by the artist Louis Wayne as he sank deeper and deeper into psychosis. Disorganized speech is another symptom. The speech is disorganized in the sense that it's incoherent. It's difficult or impossible to follow what they're saying because they frequently change topics. Sometimes the changing of topics and going from one topic to another in a not logical sequence is called loosening of associations. The ideas are not associated with each other. Clang associations are when people's speech becomes such that there's no logical connection, but that the individual components of the speech rhyme with each other. The disorganized behavior is when people act in strange ways, like they move their limbs in odd ways, they don't take care of themselves, they don't dress well, they don't bathe. This can be extremely upsetting for those around them. Negative symptoms are things like avoiding eye contact, social withdrawal, blunted emotion, slowed speech that's monotonous. These are more common in men, and negative symptoms are associated with a poorer outcome. Schizophrenia does run in families. If one twin, say, has schizophrenia, there is a 50% chance or so that the other twin will. There's also a 50% chance that they won't, suggesting that it is a combination of genetics and environmental stressors. It's a good example of something that fits the diathesis stress model. It's usually diagnosed when people are in their early 20s to 30s, sometimes a little bit earlier. There are cases of childhood schizophrenia, but those are extremely rare. You can see on the left the concordance of schizophrenia in people who are related in different ways. So, for example, if your identical twin has it, you have almost a 50% chance of developing it. If you have two parents, same thing. And as you get further and further from the in terms of relatedness, you're less related to someone with schizophrenia, your risk continues to drop. You can also see on the right, these are pictures of, these are brain scans of a normal brain on the left and a person with schizophrenia on the right. You can see on the right there's shrinkage of the brain, particularly around the ventricles, those kind of butterfly shaped holes in the middle there. Clearly, environment makes a difference as well. People who are genetically at risk for schizophrenia are more likely to develop it when there is stress involved. It's more common in urban settings, suggesting that perhaps that has an effect. So you can see that there's a relationship between genetic risk and environment that determines the risk for schizophrenia.